Hello. You are welcome once again to yet another of our several broadcasts. This one is mainly educational. It's a YouTube training which we started just giving you a few clips of radiology features. But before probably I go into it, I want to say that this is on our MIC website. On the MIC website, on the MIC, that is Medical Imaging Consultants. And this is where we do all the radiology services. We can offer all radiology services, ranging from MRI, CT scan, X-ray, and ultrasound. And of course, our reports are ranked very high, especially in our referring doctors. And of course, we are glad to give you the proper reports. We are located behind the Wandegeya Police on that building called Africots, right behind the Wandegeya Police. And we are open 24 hours. So for any radiology work, we are welcome. You are welcome. We will serve you to our best. My name is Dr. James Senoga. I'm a consultant radiologist, with more than 30 years of experience. And of course, I also lecture at ECU. ECU is Ernest Cook University in Mengo. I lecture to radiographers mainly, but also to radiologists. The presentation today is about chest pattern, is titled Chest Pattern Recognition Made Easy. Here I'm going to mainly looking at a chest X-ray. As you can see in those images, we are all tempted to put it up like you see on the screen there. People put up, one of them is even putting it the other side around. Everyone wants to get some information from an X-ray. You go to the hospital, the doctor does the X-ray and gives it to you, and sometimes very confusing, of course, for the patients, but to my radiographers and the radiology imaging technologist, this is a must nowadays. You must be able to quickly get the signs of course, if you are a medical officer, a chest X-ray will come and you're working without a radiologist. This is very important for you, that you may get a quick preview, before the radiologist come in, you already can treat the patient in the right way. So today's session is about that, and if you are to that, you are welcome. Please like the video and sign in so that we can always be able to produce these videos. Now, the approach to report writing can be very interesting, and it can vary from departments to departments, hospital to hospital, and it also varies between radiologists. So, but there are some aspects of the report which are always constant. And as one is approaching, trying to make a report on this radiograph, first and foremost, you must ask yourself, what was the presenting symptom? Is it cough? Is it fever? And these may be a guideline. But more than that, when one quickly looks at a radiograph, one should be able to conclude what the disease processes are. Just like you see here, we approach the radiology interpretation by looking systematically at the whole radiograph. When you look at that chest radiograph, you must look at all aspects of it. What do I mean with that? You look at the chest wall, you can either move from in, out, or out, in, but I usually want to move from out, in. What I mean is that I start by looking at the chest wall, going into the pleura, go into the hemidiaphragms, Then I go to the hemidiaphragms, and then finally I look at the lungs. And this is what usually I may not write the report in that form, but this ensures that I've looked at each and every aspect of the chest radiograph. Needless to say, before one attempts to interpret a radiograph, quality is paramount. You have to ensure that the radiograph is of good quality, because if the quality is compromised, so will be your findings. So it's very important. Now, here you start by concluding and knowing where you are going. For example, if you are talking about, if you think these features are due to pleural effusion, then you know you are going to conclude pleural effusion. So here we mention the positives for pleural effusion, and of course we also mention the negatives, and then we conclude. So that is roughly what we do when we're looking at the report. But this will come even more clearer as we go by. Today's session is lengthy, but we shall make it as brief as possible, and it is put under those 8 groups. That is the general quality issues, that is the common faults, which are in the general quality issues. We're going to look at the common faults, the radiology anatomy, plus the common processes that are used. Then also we shall look at features of a well-taken radiograph. When do we say this is a well-taken radiograph? And of course, after that, like I said, it should be a systematic study. We are going to look at the chest wall, and here we are interested in the skin, in the soft tissues, in the bones, their displacement, their densities. Following that, we shall look at the pleura. Here, the pleura, again, we look at whether it is thickened, displacement, fusion, and all these things. In the hemidiaphragms, one is interested about the levels of raising, either one is higher than the other. The other aspects, like I said, we go from the mediastinum, we go from the hemidiaphragm, we go to the mediastinum. Of course, this also includes in the cardiac shadow. And then finally, we look at the lungs. We want to look at the lungs finally, because this is many times is where we have the disease processes, and that's how we shall be handling these sessions. Right away, without wasting any time, I'm going to start with what a normal X-ray looks like, how a well-taken radiograph will look like. Right on the screen there, if you can see the screen, is a well-taken radiograph. And quickly we look at the factors, penetration, that is the KV. It should show up to T4, that is 1, 2, 3, 4. Yes, and you should be able to make out the cardiac shadow. Just make out the disc spaces behind the cardiac shadow. And of course, we talk about the equidistance between the ends of these clavicles to that arbitrary line drawn into the spinous process. So that means the patient is not rotated. That is very important as far as studying the mediastinal structures are concerned, and also the cardiac shadow. The other aspect of the quality is we need the patient to be in full inspiration, and this can be demonstrated by seeing how many ribs do we see. When you look at this radiograph, you realize that we have 2 sets of ribs, those which are slanting like that, and those are the anterior ribs, and of course those which are fairly horizontal are the posterior ribs. So here the anterior ribs are 1, 2, 3, 4, 5, 6. Usually 6 to 8 anterior ribs is what is acceptable, or 9 to 11 posterior ribs is what we take. The partial inspiration, of course, distorts not only the cardiac shadow and the mediastinal structures, but also prevents us from studying the bases quite clearly. So we insist in a fully inspired view. And of course, what we are looking at here also is that these clavicles, they should be out of the field of view, and it should be in an AP. It should be in a PA view, a PA view. When it is in a PA view, that means the scapulae are out of the field of view, and then you are able to generate a good. Those are some of the major aspects of a well-taken radiograph. And on my side here, you can see that some of them which are not worth reporting. For example, this one, the epices are cut off. You don't see the epices. On this one, the KV is slightly higher. And of course, the inspiration is not adequate. This is what I was meaning. You count 1, 2, 3, 4 anterior ribs. So this is under inspiration, which distorts the cardiac shadow, and of course also you are unable to study the bases, but that's because of that. When the KV is quite high, it burns out the lungs and you're not able to see anything. However, due to this, we also want to say not all visualized vertebral column may mean that this vertebral column may mean that the KV is low. Sometimes the pathology may be that the vertebral body is seen, and so on and so forth. These are some of the techniques, the radiographs, where we want them done very well. Okay, so that in a nutshell is what we look for in a quality. You must ensure that the radiographs are proper before you interpret them. The next slide shows us the processes, some of the common processes, and it is important and imperative that you know this, you as a technical person, because sometimes they may be in the clothes, but make sure they are not part of the clothing, or if this is some of these, like for example, this is a pacemaker, this is a breast implant, a breast pump, and these are some of the prosthetic valves, and these are breast prostheses, the silicone type, and of course these are the valves. It is very, very important that you appreciate these and you know these are not pathological. The drains, sometimes the doctors may refer patients to be able to locate the drains, and of course the leads, the ECG leads, and so on and so forth. The endotracheal tube is also something we look out for, and of course the vertebral clips. So much for the quality and the prosthesis. So what we are saying is that before you attempt to interpret a chest radiograph, one must first and foremost ensure that, sorry, it's raining quite a lot outside, but I hope you can hear me well. Yes, first you establish that the quality of your radiograph is ample, and then it enables you to read the radiological sign. The second thing is about processes. Make sure the processes which are there are not taken as that. Now, when we start our evaluations, like I said, we want to start with the chest wall. And the chest wall, this means we look at the soft tissue, and when we are looking at the soft tissues, we are looking at the size, we are looking at the densities, and if there are any lucencies within these. Of course, we are talking about the subcutaneous emphysemas and so on. And of course, in the chest wall also we look at the different body structures, like the sternum, the ribs, and the vertebra. And close to this, we are talking about the change in density. Sometimes we may have fractures, just like shown in this radiograph here. I'm talking about the soft tissues there, the ribs, and the clavicles. Close to this, again, we say this is the next slide, which shows us a bit of the pathologies, and this is why we look at the chest wall, and we say that yes, this chest wall may become bulky, like you see here. The chest wall may become bulky or thickened, especially when one is talking about the trauma but of course also rib fractures. As you can see in some of these image 5 shows us the rib fractures, and of course the lucent areas which show the subcutaneous emphysema. So this gives us a view. Before you make or you attempt to interpret your radiograph, make sure your chest wall is normal in terms of size and densities. And here shown are some of the examples which are shown here. The other bony structures like the vertebra can also be evaluated, and here we talk about the scoliosis. Okay, of course, when we are reporting the scoliosis, we can say either it is an acute scoliosis or smooth scoliosis with the concavity to one side. Like you see in this image, it has concavity to the right. On the other side, we can get kyphosis on the lateral aspect, and it can be a sharp or smooth kyphosis. And here also that depicts in the bone structures. The other aspect, of course, of the bones is the soft tissues, and tumors like this may be demonstrated originating from the bone, and these are best demonstrated by a CT scan. Yes, so in a report, if you are thinking about a report of such a radiograph, again, in summary, I said quickly, we talk about the quality of the radiograph, and here we say probably the left hemithorax was cut off, but otherwise, the other thoracic elements are shown. And we start, much as we may look systematically at each and every aspect of the chest, but usually we want to start with what is pathological, and then we can describe it. Like in this report, I started straight away with what is pathological, and write that there is marked thickening in the right chest wall with soft tissue, extensive linear lucences extending to the neck, most likely due to subcutaneous emphysema. Multiple rib fractures as noted in the same region with the chest deformity. So I'll do that, and of course I'll also mention the patchy alveolar lung infiltrates that are seen in the mid and lower zones, confluent in some areas with associated reduction in the lung. So that will be my report, and then the conclusion will come in and say these are features of post-traumatic chest. These are post-traumatic features, sorry about that, with a right subcutaneous emphysema, rib fractures, and extensive lung protrusion, the CTs. So a report like that would be very acceptable in such a case, especially when we are reviewing the chest pathology. And like I said, usually we want to start with the conclusion in mind, and then we look out for the features which may be in keeping with the conclusion, and of course we look systematically elsewhere, and then of course we want to mention the pathology and describe it to the detail just like we have seen here. I think that gives us a hint of the wall. We can proceed on and look at the other aspect, the pleura. Now, when you're looking at the pleura, these are lung coverings, and of course we want to examine whether they are thickened, they are displaced, whether we have a pericardium, pleuropericardium, or we have a effusion, we have a hydropneumothorax. All these are very indicative of pleural anatomy. In this diagram, just roughly to show you what we look at when we're looking at the pleura. Of course, on the left, we have two lobes, the upper lobe and the lower lobe, shown in blue there. And on the other hand, on the right, we have three lobes, the upper lobe, the middle lobe, and the lower lobe. Here, again, shown in those colors. And what we normally see on a brain radiograph is that transverse fissure. The transverse fissure is usually on the fourth anterior rib. That is where we get it. So when you know where the pleura is located, then you can quickly tell about the pathologies. Like in quite a variety of these. Commonest is the pleural effusion, and the pleural effusion is seen by this rather lamellar hyperintensity or increase in density along the chest wall, and of course we see that there is that meniscus sign. Once we see that, then we say there is a pleural effusion. In this image here, we see that this is a supine image, and of course the patient was lying down, and we have that layering off of the fluid, and also suggests a pleural effusion. Other conditions like a loculated pleural effusion may also be described. A complete pleural effusion may appear like that, with complete homogeneous opacification of the hemithorax, with the minimal displacement of the trachea, can be seen as a complete pleural effusion. The hydropneumothorax, on the other hand, may be seen by a transverse line, a linear line like that, which is a an air-freed level. With an air-freed level, then we say there is both air and freed, which is hydropneumothorax. So these are some of the cases where we have the pleura in question, and of course some others which may include pleural thickening, may include pleural masses like those, pleural-based masses which may be extending into the lung. Like here we see it, it's really pleural-based and extending into the lung, and so on and so forth. When it comes to describing the pleural effusion, again we want to write a report which could be like that. The main findings here is the homogeneous opacity in the right lower zone with the positive meniscus sign. Here I'm talking about that sign up there, and the silhouette sign with the mediastinum and the hemidiaphragm. These are features of moderate right pleural effusion. On the other hand, I have already talked about this. When you have it complete, we tend to have generalized opacification over the left hemithorax, denser in the lower zones with minimal mass effect, and that's when we can talk about the mass effect, with the massive pleural effusion. So those are some of the elements which one looks out for wherever you think about the pleura. So from the chest wall, we've looked at the soft tissues, the bones, and then we have gone inside a bit. We've looked at the pleura. Is it thickened? Is it displaced? Do we have effusion within it? Do we have air hydropneumothorax? And all these can constitute your report. Next on our study is the hemidiaphragm. And again, the hemidiaphragms, like I said, they are normally located at the level of the 6th to 8th anterior rib. But sometimes they may be raised, like you see in this image. You get a unilateral raise in the hemidiaphragm. And this may be due to a lot of causes, but commonest could be the abdominal. Here, we would like to classify them into three. They are those which are above the hemidiaphragm, like the phrenic nerve palsy, like the consolidations. All of these could cause unilateral raise in the hemidiaphragm, to conditions within the hemidiaphragm itself and below the hemidiaphragm. So when you look at a raised hemidiaphragm, those are the possible causes that could go through your mind. So you need to look, is there a tumor? Is it below? Like in these cases, we have it being caused by below. Or is it a liver tumor, like in this case? Okay, and then it raises. But on the other hand, it could be due to a pancreas tumor compressing on the phrenic nerve there, and then we get the phrenic nerve palsy. Or it can be a diaphragmatic hernia. And all these can come in very, very handy wherever one would like to interpret a radiograph. So when you look at the radiograph, after looking at the wall, you looked at the pleura, it's very important that you look at the hemidiaphragms. Are they flattened? Like in this case, they are usually flattened in conditions where we have air trapping, like in those chronic obstructive airway diseases. Or is it raised? It can be bilaterally raised in ascites, or it can be unilaterally raised in those conditions which are made up. So it is very, very important also eventration and the deformities in the hemidiaphragms. Good. That covers the hemidiaphragm and the conditions in the hemidiaphragm, and we are ready to go to the mediastinum. Like I said, we come from up there, and we say how long, what have we recorded already. Then we say we start from the wall, look at the wall, look at the pleura, look at the hemidiaphragm. Next, you want to look at the diaphragm before you go, the mediastinum, before you go to the lungs. Now, the mediastinum here, the important thing we want to look out for is any change in position. Again, like I said, when you're going to study the mediastinum, it is very, very important that the quality of the radiograph is ample. We need a fully inspired radiograph, we need a PA, and we need someone not rotated. Now, the change in position, shape, size are some of the aspects we look at when we are looking at the mediastinum, and the possible causes like the possible causes like the chest, diaphragm, and the anterior mediastinum, they come quite handy. Yes, I think let's start from there. And we discuss the mediastinum in detail. Thank you very much.